Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, my name is Molly Casey. I'm on the marketing team for Axxess, and I would like to thank you for joining us for today's webinar, where we will hear from two home health experts on recent relief measures the federal government has provided in light of the COVID-19 pandemic. Today's webinar is brought to you by Gateway Home Health Coding and Consulting and Axxess. The mission of Gateway is to provide better, faster, and more affordable coding services to home health and hospice providers, all in an effort to improve agencies' operations and bottom lines amid payment reforms. Axxess is the leading technology innovator for healthcare at home, offering a complete suite of easy-to-use, innovative software solutions that empower home health, home care, and hospice providers to grow their businesses while making lives better. Joining us today are Arlene Maxim and Joe Osentowski. With many years of nursing experience, Arlene Maxim previously co-founded regional multi-million-dollar Medicare certified home healthcare companies, hospital-based home care and hospice companies, and transitional care programs. In her role as clinical consultant with Axxess, she applies her extensive knowledge and expertise to her speaking opportunities, training, and consulting. Joe specializes in additional documentation requests, responses, and appeals. As a registered nurse for more than 25 years, his career has included clinical consulting in home health and hospice, specializing in clinical quality assurance and regulatory compliance. He also has extensive experience with all types of Medicare audits and probes from the variety of Medicare contractors. Joe is the author of the book, The ADRs and Appeals Handbook, first edition from Decision Health. Joe serves as clinical consultant for Gateway Home Health Consulting and Coding. Before we begin, a few housekeeping items. Axxess will be providing 1.5 continuing education credits for this webinar. All registered attendees who want to receive those credits must be present for at least 60 minutes of today's webinar and complete the post-webinar training evaluation. Certificates will be emailed to individual emails registered for this webinar. Your phones have been muted, but we would like you to ask questions using the question functionality. At the conclusion of the webinar, both Joe and Arlene will be answering the questions submitted via the question functionality. The presentation slides are posted here in the handout section, and we will also send them as well as a recording of the webinar at the conclusion. Arlene, over to you.
Well, thank you, Molly, and thank you everyone for attending today. This is a real treat to be speaking with Joe on this Tuesday afternoon. As Molly said, make sure that if you want your CEUs, you complete all the information that's necessary. You get that taken care of at the end of this, and you have to be attending at least 60 minutes. So just be sure you get that done. So what we're going to talk today about the certifications and the face-to-face for home care and hospice, which is now able to be done by the NPP or the physician, and it has to be a face-to-face in telecommunications. So the face-to-face requirements has changed a bit, so the patient doesn't have to go into the doctor's office to have that done. So that's a really good thing for us. There are things that are changing every single day with us, so we are bringing you the most up-to-date information today, but things may change again tomorrow. So the use of telehealth and home care we're going to talk about today. We're going to talk about the NPP assigning plans of care, the 14-day supervisory visits that no longer have to be done on site, other state rules, and then using temporary rules to do a little more marketing than you have had opportunities to do for prior to this. So the Trump administration, again, has issued unprecedented temporary waivers for home care and hospice. And that's been a huge help to all of this during the pandemic. I just saw something on Facebook a couple days ago that I was actually involved in a pandemic back in the 60s, and I didn't even realize that. But this time we all know what the pandemic is causing, and we've had some relief measures given to us by the federal government so that we can continue to do our work, continue to see the patients, and try to continue to have good outcomes. So the goals of the actions for the administration was to make sure that the local hospitals and health systems had the capacity to take care of the COVID-19 patients. We understand now that some of the hospitals did have the capacity, some of them did not. Most of the problems that the hospitals seem to have had to do with not having enough PPE. Of course, we heard about the ventilator shortage in New York, and that seems to be relieved now, and things seem to be getting better. Another action had to do with removing the barriers for physicians and nurses and other clinicians that are hired from other states. So they relieved that requirement to have the licensing where you actually perform the services. So your licensing requirements have the licensing requirements are no longer there. That you have to be have a license in the state that you're working in. So some of the New York hospitals had people coming from all over the United States to work in that hospital and didn't have to have a New York license. There was an increase in telehealth and Medicare to ensure the patients had access to physicians. So although they still are not paying home care hospice for telehealth specifically, we do have access, and we'll get into that a little more as we go through these slides. Expand in-home testing, in-place testing to allow for more testing at home and community-based settings. That testing is now going to be going nationwide. I understand from the news this morning that there's testing for everyone. So as you see the testing being done throughout the United States, of course, you're going to see those numbers of people that are positive going up. That does not mean that the epidemic is worse. It just means that there are more people being tested. But you'll have the opportunity, likely have the opportunity to be testing in the home, in the homes that you go into. Put patients over paperwork was the fifth relief measure, and they were trying to give us temporary relief. Joe's going to go into some of that, particularly with the audits that are being done. So some of that was helpful for us. Much of that was helpful for us during this epidemic. Home health agencies can provide more services now using telehealth in the 30-day episode. We have the ability now to use the technology as long as you have the information on the plan of care. So the CMS sees telehealth as a tool to reduce the agency cost, and they don't count toward the LUPA. So you have to make sure that on your plan of care, you are including telehealth as a plan of care order, and you have to talk about what you're going to do with telehealth, whether you're going to be doing vital signs, SaO2s, what you'll be doing specifically with the telehealth, how often you're going to do telehealth, and what you're going to be using. So they are telling us now that they're going to relieve the HIPAA requirements so that you can use FaceTime and Skype and that type of thing for your visit. So that's helpful. So the HIPAA requirements for that is loosened up quite a bit. But you have to be careful that you don't bill for that. It's interesting because we've been experiencing some surveys recently, and they're checking on infection control, but some of the surveyors are also asking about telehealth and asking whether or not the agency is billing for telehealth. So be careful that you don't, your biller, if you're a large agency, your biller doesn't make a mistake and bill for your telehealth visits. Make sure you're only billing for in-home visits. For hospice, we're also allowed to use telehealth in hospice, particularly with the face-to-face encounter requirements. You can bill for the services. The hospice physicians can bill for the telehealth services, but the hospice itself just bills lump sum that Medicare allows for billing. So, and the waiver requirement for the hospice for the use of volunteers. So you don't have to put the volunteer out now, and that including 5% of patient hours is not a requirement any longer. So you don't have to have volunteers go out to see your patients at this point in time. So the plan of care, the NPP assigned for plans of care for during this period. The original order, or the original waiver, I'm sorry, indicated that we would need to have NPPs, we were allowed to have NPP assigned plans of care during the epidemic. And just recently, they increased the ability, the NPPs, and this will go past the epidemic. This will be a permanent change. So your NPPs will be able to sign your plans of care from now on. So it's not just, this isn't a temporary measure. This is a permanent measure that's been put into place. This is just the information about, this is directly from Palmetto, about the ability for NPPs and PAs and CNSs to actually certify the patient. And again, this will be a permanent change. The 14-day supervisory requirement, this is a blanket waiver that for the on-site visits of Aide supervision, you don't have to do on-site, you can do actual telephone calls. It doesn't have to be the same as telehealth where you have to visually see the patient. This 14-day supervisory visits can be done via telephone. And of course, that was, again, a really helpful thing for us. The standards of practice for licensing, again, as I mentioned earlier, the state practice acts were waived during this period, so nurses can go, and therapists can go from state to state without getting a license in that particular state that they're working in. One of the things I thought was really interesting, we have these temporary rules. We need to look at what are the opportunities for us in getting referrals. So now we can go to NPPs and PAs to get referrals, and we weren't able to do that in the past. So in some states, the NPPs actually have their own practices. So this will be really helpful for us as we start marketing to more folks once this epidemic is over. The COVID-19 patients in hospitals and non-COVID at home will be something you're going to have to pay attention to. More patients are coming home with out of the hospital, and the non-COVID patients are being seen. Oh, sorry. A lot of patients are coming home, and the non-COVID patients at home will be screened. We recommend that you're doing the screening each time you go into the home, and then using telehealth to leverage referrals from nursing homes. The nursing homes are looking very carefully. They don't want to have these patients coming back to them. So this is a really good referral source for you, going to the nursing homes and letting them know you have telehealth and letting them know you'll be able to do a better job than maybe another agency that is not using telehealth to their advantage. So this is a really good, this is another good opportunity for all of us in home health and hospice. Your clinical records, and this is just information talking about in accordance to this section, they're extending the deadline for the requirement that the agencies provide a copy of their patient's medical record at no cost during the next visit. So they're giving you 10 business days actually. If the patient requests their clinical record, they're giving you 10 business days to get that to them rather than the 4 that is listed in the conditions for this patient. Discharge planning, we've had some pretty specific rules in discharge planning, and they've also waived them. So they're waiving the requirements, requiring discharge planning for the patients and the caregivers, the patient's representatives seeking a post-acute care provider by using the data that's available through Home Health Compare and Healthcare Compare. So they're just waiving all of those requirements. So the discharge requirements are not going to be as specific. And I just wanted to make a comment here too. You have to be really careful that your staff does not get used to these exceptions during the pandemic and during the national emergency, because as soon as this pandemic is over, we have to go back to the strict requirements that we had originally. So you want to make sure that all of your staff understand that. Training and assessment of aides, they are waiving that at this point. So the specificity in requiring the nurses to do the training and an on-site supervisory visit is now an exception. So you can postpone those until after the national pandemic is over. Your annual in-service training, your 12 hours are also been an exception here. So this allows the aides and the registered nurse to spend more time delivering patient care. So they're going to postpone all of these requirements. QAPI, what they want you to do with QAPI is to really, really concentrate on your infection control. And so you won't necessarily have to have all the specificity that was required with QAPI in the past, but be very, very careful that you are following all your infection control measures and you are keeping track of that. You're reporting to your health departments if you have any COVID-19 patients or personnel, and tracking any adverse events related to the lack of PPE. And so again, this will be something that will need to start once we get past the national emergency. On-site aid supervision, I think I already went over that. The waiver temporarily suspending the 2-week supervisory visits. You can do the virtual visits via telephone, and that's fine. So if you don't get it done exactly on the 14 days, it looks as though they're probably going to look over that, but try to stay as close to the 14 days as you can, and you can do that virtually. OASIS Transmission, again, they're extending the 5-day completion requirement to 30 days. They're waiving the 30-day OASIS submission requirement. They delayed the submission is just permitted under this national emergency. They're allowing 30 days for the completion of the comprehensive assessment, so that you've got 30 days from the time you admit the patient to get that comprehensive assessment done. And then you have to submit, of course, the OASIS information prior to the final claim. So make sure you have some tracking mechanism for that. And also be sure that you have the information available for your surveyors, and you have this changes once that national epidemic is over, and you go back to our transmission the way we had done it prior to the national emergency. Quality reporting program, the agencies are going to need to collect the transfer of health information quality during the standardized patient assessment data elements. This is going to be, let's see, the transfer of health information quality measures in certain spades on January 1st of the year. That is at least 1 calendar year after the end of the public health emergency. So there's a lot of flexibility built into there with your quality reporting. From what I understand, CASPER isn't going to update until October now. So the agencies that don't submit the data aren't going to have that 2.5% or 2%, I'm sorry, taken off of their claims until after the 1st of next year. Value-based purchasing is implementing a policy to align the value-based purchasing submission requirements with any exceptions or extensions granted for the purposes of home health quality reporting during the public health emergency, as well as policy granting exceptions for the new measures during this pandemic. Your initial assessments, again, by waiving 44.55A, the agencies can perform the initial assessments and determine the patient's homebound status remotely or by record review. Again, this can be done, this is supposed to be like a telecommunication, so you're supposed to be able to look at the patient, and this is not necessarily just telephone. It has to be something that you're going to actually be able to do with Skype or FaceTime. This will allow patients to be cared for in the best environment while supporting infection control and reducing the impact of the acute care and long-term care facilities. So this is another thing that they give you 30 days. You get your initial assessment done, determining eligibility via telehealth if you have telehealth available, and then you have 30 days to get the entire comprehensive assessment completed. The RAPs, the MACs can extend the auto cancellation of RAPs, so the auto cancellation is not going to be taking place. This is a prepayment. Joe's going to go into more of this, the RAP payment, that the way it currently exists, and some of the exceptions when he does his session. Occupational comprehensive assessment. It has been, we have been fighting for this for a long time, for occupational therapists to complete comprehensive assessments, and now they are allowing the comprehensive assessment to be completed by occupational therapists. The other thing that just came out recently was that the assessments can be done by speech or PT, even though skilled nursing is involved in the case. So if you have an assessment that needs to be done and you can't get a nurse out there within the period of time they need to go, you can have one of the other therapists complete that, even though nursing is also ordered on the plan of care, which is something completely different than we've been used to in the past. Referrals for patients with known or suspected COVID-19, they've relaxed the homebound status during the crisis, therefore more referrals can occur. A beneficiary is considered homebound when their physician advises them not to leave because of the confirmed or suspected COVID-19 diagnosis, or if the patient has a condition that makes them more susceptible. So you'll have to analyze that with each one of your patients to determine whether they're susceptible or not, and whether or not they have a suspected COVID-19 diagnosis. As a result, if the beneficiary is homebound due to COVID-19 and needs skilled services, the agency can provide the services under Medicare home care benefits. So they've added the COVID-19 as part of the eligibility for home health. Another change that allows the agencies to perform initial assessments to determine the homebound status remotely or by record review. This isn't the same as an initial assessment. The initial assessment is a comprehensive assessment, but you can determine eligibility with a phone call as long as you can visualize that patient using FaceTime or Skype. NPs, PAs, or CNPs have been given temporary permission to refer patients, and they can sign their own plans of care, and they can also sign their orders. Again, face-to-face is provided remotely. I covered that earlier. And be cautious accepting a patient for which you don't have enough staff to cover. And that's been a problem with a number of agencies where they they're taking the referrals and they don't have staff to get out there for a while, whether the patient's not letting them in or they are just short of staff. So be really careful because the complaint surveys are still going on. So be careful of that. Be aware that the infection control surveys and the complaint surveys are still going on. So if patient or caregiver has a complaint, you may still have a survey. Make sure that you're not that you're covering all your bases just like you would during regular home care times. Patient and the family refuses to have staff in the home. There's certain documentation you need to have in the clinical record, and I would advise you to go back and look at the conditions of participation where they talk about refusals in the home. The specificity of the documentation for that is a little different than the patient who has has a missed visit. The missed visits have to be reported to the doctor. Refused visits, the staff have to actually instruct the patient what what damage could be done to them or what the harm could be done to them by refusing the visit, not getting enough education, maybe not having their wound care done. If staff members are reluctant to visit, you have to make sure that you've got a clear documentation of that, and you have a way to staff with alternative staff. The agency is understaffed due to illness or family issues. You're going to need to make sure that you have enough staff to take care of the patients that you're accepting referrals on. The visits cannot be done remotely. There's a huge misconception about that, and people are thinking just because we can do telehealth, they can do the actual visits remotely, and that's not so. You have to make sure that you continue to do your documentation. Axxess has a wonderful telehealth note that they just put online within the last month, and so those Axxess users have the ability to document their telehealth very clearly, and there's no doubt that it's a telehealth visit as opposed to an on-site visit. So the only visits that can be billed right now are your actual visits that you have listed on your plan of care and the care that's to be provided during that telehealth visit. The other reason for missed visits has to do with the general fear that staff, patients, and family have regarding this virus. And so making sure that you have the proper PPE in the agency, making sure that the agencies or the patients have some PPE available to them when the staff is going into the home. And then making sure that you've got the documentation if you're doing a premature discharge, that you've got the documentation to support why that discharge is being done. So in handling missed visits, of course, like I said before, the doctor has to be notified of all of those visits. And so that documentation has to be very clear as to why the patient wasn't able to be visited and when you'll be going back. If the patient refuses a visit, try to reschedule the visit during that Medicare week that you have assigned. If they're not able to make that up, then you're going to have to make sure that you notify the doctor that you weren't able to make that visit and maybe ask him or her for an order to increase visits the next week if that's necessary. If the patient's refusing a visit indefinitely, you really need to discharge that patient. And then you have to notify the physician and either have the primary clinician do the discharge based on their last visit if they won't let you back in the home. If the primary clinician is not available, then you need to have another qualified physician or clinician do the discharge. Make sure you do a really good job of documentation. I would expect that Joe and his staff are going to have an interesting time when this is all over, when they start getting medical reviews, particularly with the frequency of visits and the missed visit. Surveys will also be interesting over the next year. And so you want to make sure that you have the documentation to support everything you're doing. Unexpected discharges, of course, the assessment itself requires an in-person visit. The assessing clinician can supplement the discharge visit with information. Again, try to get that done within the last 5 days that the patient's receiving visits. and that date of the discharge visit then needs to be documented within the 4 preceding days. But there's going to be a lot of flexibility, I think, here when we do have to discharge a patient. So just making sure that you have the really, really good comprehensive documentation to support whatever it is you're doing. Your missed recertifications, they're still due within the last 5 days of the episode. And try not to do these missed certifications. You can make them up, you can do a late certification, but try to get them done as timely as you can. If the recertification is missed because the patient's refusing the visits, you may again need to discharge that patient. And you can't put the patient on hold indefinitely. That's just not possible. So make sure you try to keep up with all the visits that are ordered on your plan of care. Okay, Joe, I'm going to turn this over to you. Thank you.
All right. Thank you so much, Arlene. Well, the next component of today's presentation, and thank you all for attending, is really in relation to medical review, ADRs, review choice demonstration and appeals. But a lot of this is going to hopefully link together the items that Arlene went through so that when the public health emergency is done, you are in a proper position so that any medical review that occurs will not cause you financial difficulties. So I want to go through some items about what's changing and then try and put these together into clinically how can you address these currently within the public health emergency, and then things you need to be planning for when the PHE is over. Oh, good, I can advance the slides. So we're having a technological benefit today. All right, medical review changes during the public health emergency. Yet another acronym for us. Let's see, and then advance again. Now, CMS and medical review. Okay, all of Medicare's generated medical review, you can see that's capitalized, so it's a very specific reference, is suspended during the public health emergency. And that's CMS generated medical review. And this will apply from the date of the public health emergency being initiated. There's a lot of dates floating around because Health and Human Services Secretary issued a date, the President has a date of emergency. There's all these different dates. Basically, I'm going to make a assumption here and say that any home health service you're providing right now is going to be within the public health emergency. So these waivers of requirements that Arlene had gone through, and I'll go through some more, apply to your records. And then what's going to be a really interesting part is when there will be a defined end of the public health emergency. And as of that date, everything that we did before the public health emergency, with a few exceptions, is going to apply again. So knowing what's relaxed or what is waived right now is important, but also then planning, as Arlene just mentioned, that when the emergency is over, most things we had to do before are going to be in effect again. So we need to be careful about when things apply to what records when. So CMS generated medical review suspended. This applies to the biggest group being targeted probe and educate reviews, or TPE. These are issued by the administrative contractors, 4 regions, 3 contractors, Palmetto, National Government Services, or CGS administrators. That's the one, if you were selected or targeted, you're probably most familiar with. Recovery audit contractor reviews done, there's only one contractor in the entire country, Performant Recovery, Region 5. It has suspended activity. And then the supplemental medical review contractor, who's Noridian Services, also has suspended review. Now, this suspension of ADRs and review from Medicare basically applies to both prepay and post-payment reviews. A prepayment review, of course, is when you bill the claim before you were actually paid the final amount on it. The claim goes to medical review. And then post-payment reviews are look back, meaning claims have already been provided, service been provided, claims been submitted, and then these claims are reopened and reviewed. So right now, there should be really no TPE, which are prepay reviews, no RAC reviews or SMRC reviews, which are post-pay reviews. And that will be for the duration of the public health emergency. Let's see, slide advance, yes. So what happens to each of these types of reviews? The targeted probe and educate, no ADRs are being issued right now under targeted probe and educate. TPE probes that are in process will not receive further ADRs. And if you unfortunately were part of this, you, I'm sure, are aware of this by now because we've had enough time since the emergency has gone into effect. But TPE probes will not receive further ADRs. But understand, this is a suspension during the public health emergency. So my latest information is that really, if you're under a targeted probe and educate review and you're currently not going to go to the next round of ADRs, that is only suspended or put on hold until the emergency is over, and then you will resume your activity at that point. If you're under TPE and you're waiting for the next probe, meaning you've received your results, you're waiting for your education possibly, you're waiting in that time period after education before they go to the next level, they will not receive, right now, you're not going to go to that next level of that next probe. And then any ADRs that are in process, and you should have all basically cleared by now, that you might have sent prior to the public health emergency starting, basically they will release and pay. So they will automatically pay anything you have sent in. For recovery audit contractor RAC reviews, they're not going to issue current ADRs, and then any ADRs that had been in process that you had not yet received a result will be released from review and they'll be paid. And of course, that's similar with Meridian, the supplemental medical review contractor. No further ADRs are issued. ADRs in process will be paid. There's another type of course, medical review that does occur, that's affected by the public health emergency, are comprehensive error rate testing, or CERT reviews. These are generally one claim post-payment reviews, and CMS has immediately suspended issuing ADRs under the CERT request. If you had an ADR you had received under the CERT request, that claim will automatically pay, so you don't have to actually send it. It should just release and pay without processing that ADR. Next slide here. Now, there are certain types of medical reviews which are not affected by the public health emergency, and CMS, Medicare, is really silent on Unified Program Integrity Contractor, UPIC activity. So basically, no matter what's going on, a UPIC can always review your claims. So while, again, MAC, Administrative Contractor reviews, Recovery Audit Contractor, SMRC reviews are suspended during this period, even though those reviews are suspended, Targeted Probe and Educate, if there is determination of possible fraud, that even the MAC, the RAC, or the SMRC could still conduct medical reviews. And that's in addition to the continued UPIC activity. So UPICs basically are always looking for possibility of waste, fraud, and abusive issues here. Many of them come from whistleblower issues regarding billing practices, certain billing patterns in certain areas. That UPIC activity can continue throughout this. And it'll be interesting to see how it applies or is applied to these waivers that occur in relation to orders and things like that. But basically understand that outlier billing activity will be possibly undergoing UPIC or under possibly scrutiny from UPIC, and then also a MAC can do reviews. Now, the last bullet point on this slide is an open issue in that Medicare Advantage or private and commercial insurers, of course, are not specifically affected by the suspension. So basically it comes down that if you have a Medicare Advantage payer, you really do need to get your contact with that payer and determine, are they going to follow these waivers? Many of the Medicare Advantage contractors outsource their review activity to other contractors. And you do need to check to see, because Medicare Advantage generally does follow Medicare's requirements when review activity occurs. But with all these waivers going on, it puts an open question whether things like non-physician practitioners or NPPs signing plans of care will be acceptable to Medicare Advantage reviewers during this period, or whether homebound definition or homebound cases would be different. So all your Medicare Advantage, as always, it's recommended. This is very similar to Medicare Advantage claims and PDGM, whether they followed the episodic payment model or whether they whether they followed under the PPS model, things like that, the PDGM or PPS model. So Medicare Advantage, you need to check with those payers, with those insurers, and see if they're going to follow these relaxed waivers during the public health emergency. Otherwise, you may end up with a mess after this from that aspect as well. Now, review choice demonstration, another type of medical review. I know this is really a limited application to today's attendees, but really, review choice demonstration was set or was going to go into effect and has gone into effect in parts of 5 states, all of them being Palmetto GBA states. So the public health emergency specifically does change that Florida and North Carolina did not start this month, last week really, if I did my math right. The choice period, though, for what option they selected did end. Florida, I believe, went 100% for pre-claim of agencies that made choices, pre-claim choice 1. North Carolina, I believe, was 98% and 2%, or did I flip-flop those? Basically, every provider in those states did choose a pre-claim option, but that choice selection period has ended. So when the public health emergency is over, then those states will receive advance notification from Palmetto, and this was confirmed on Palmetto's telephone call this week, to set up enough time when RCD will commence in those 2 states. So it's paused, but not discontinued. Ohio, of course, just ended its 6-month cycle. And Ohio agencies right now are in a selection period. There's actually contradictory verbiage on the Palmetto site, but I believe basically it's an open period. So Ohio providers can make their selection for the next 6-month cycle, but depending on what they choose is what actions they'll take. I'll go into the next slide, but basically it's an open selection. And then Illinois and Texas are within a cycle right now, a 6-month cycle, and there's specific verbiage or specific things that they'll have to do, which I will cover on the next slide. Basically, its main difference is whether you're under pre-claim option or an ADR type option. If you are under RCD pre-claim review choice 1, agencies that are currently under 100% pre-payment review, pre-claim review, you can either continue basically to submit claims for pre-claim review, obtain the unique tracking number, and bill it using that UTN. The vast majority of agencies are proceeding in that manner, and that's really the recommended way, because otherwise you're just deferring an ADR headache of epic proportions. Or an agency can stop submitting claims for review and basically bill without a UTN. Basically, you're not even submitting a claim for pre-claim. You just bill it like you would have done prior to RCD being initiated. A 25% payment reduction will not apply, but there's a little asterisk that can really be attached to that. What happens to those claims? CMS doesn't need to be informed of the choice. If you're currently under choice 1, it'll just process claims as you submit them. This affects claims of service furnished on or after late March, so pretty much any claim right now should fall within this. If there's no pre-claim submission that is made and the claim is final bill without a UTN, it will pay. For now, at the end of the public health emergency, get this, every claim that has been final billed and paid without undergoing any form of pre-claim review will be ADR'd on a post-pay basis. So when you get your 2 choices, you can say, I'll just submit my claims and get paid. Right now, understand that every one of those claims, if you have made choice selection 1, will be subject to an ADR at the end of this. And that's going to be a lot of ADRs for a lot of agencies. So really, the option comes down saying if you're under pre-claim choice 1, you might want to just consider continuing to do that. Claims that undergo the pre-claim process and are billed with a provisionally affirmed UTN, it will be momentarily here. Let me check. There we go. Pardon me. Claims that undergo the PCR process and are billed with a provisionally fully affirmed UTN will not have ADRs issued. So that's the big benefit to continuing the pre-claim submission. Claims that are processed via pre-claim and final bill without a fully affirmed UTN will actually get an ADR. So I said earlier, there'd be no ADRs basically under public health emergency, but those ones will be ADR'd. So again, it's just because they said, right, the claim wasn't affirmed for payment, you bill it. So Medicare wants to look at it. If a claim is submitted by a pre-claim, you get a UTN, and this UTN is not on the final bill, it will RTP. Meaning if you do the front end of a pre-claim and then you don't put that UTM when you final bill it, it'll get kicked back to you so that you do make sure you have a valid bill when you submit it. Let's see. There we go. Now, every other choice under RCD, choices 2, 4, and 5, basically, that use ADRs, any ADR that was in process will basically be released and pay. If you had any pending ADRs that you'd sent in and you didn't have a response, they'll pay. You don't need to follow up on them. No additional ADRs will be issued during the public health emergency. However, again, it just means a suspension, not a stopping of it. At the conclusion of the public health emergency, all claims that would have been subject to review will receive a post-payment ADR. So basically, if you're under 100% ADR review, choice 2, meaning that 1/3 of Ohio agencies that fell under this who did not make a selection, that significant number of Texas agencies that did not make a selection, once the public health emergency is done, you will get ADRs on every one of those claims. If you're under choice 4, the statistically valid random sample, I just love saying that, the number of ADRs to be pulled will be calculated by the number of claims you submit, and then you'll get your ADRs when the public health emergency is over. If you're under spot check, again, they'll calculate it based on the claim submitted, and you'll get your ADRs upon completion of the public health emergency. And if you had somehow, to that less than 1% of agencies that ever selected choice 3, you were locked into that for the remainder of the public or the review choice demonstration, and really nothing changes during this period. Let's see. Medical reviews and regulations. This really goes back to a lot of what Arlene had started on, in that any suspended or altered regulations that vary from pre-health emergency requirements should not cause denial. So basically, Medicare has basically said, you know what, we put these waivers in place, such as non-physicians certifying and signing physician orders, or signing orders now, I should say, and we're not going to come back and deny you on that basis. Also, this applies to certification. So basically, the relaxation was, and when it was temporary, this meant it was a big, huge news. And now that just last week, they've clarified that NPP signing orders will continue after. This even is in one way it makes it a lesser importance, but on the other hand, it also means that you're not going to be held responsible to this once the public health emergency is over. They're not going to come back and say, an NPP signed that order on May 12th, therefore we're denying you because it wasn't a physician. And that's really good news for agencies. Also, the waivers regarding surveys, home health aid issues, which are a survey issue, home health aid supervision, home health aid training, anything that they would survey you on that has been waived should not result in a negative effect when surveys are conducted after the end of public health emergency. So they won't come back and then say, well, we gave you these waivers and now we're going to hold you to what you did because we waived those requirements. Same for OASIS completion requirements. But if possible, here's kind of like I'm not going to say best practice, it's recommended, and taking into account the administrative burden, because certainly CMS has given a lot of waivers for many different things. OASIS completion, who can do the OASIS, the timeline of it, who can sign orders, who can certify, some homebound, telehealth. There's all these different waivers that they're giving agencies to give them flexibility. But if you can maintain your pre-public health emergency requirement standards, that is really your best defense against any problem when the PHE, public health emergency, is over. So again, it's that burden of, you've given me these flexibilities, we appreciate it, but if these flexibilities are going to cause me problems after, you might want to consider how you actually apply these flexibilities to your agency. And that's really reinforced. This is directly stated from Palmetto. It's in relation to RCD, but I think it clarifies quite nicely the status, which is providers and suppliers must resume compliance with normal Medicare fee-for-service regulations and rules as soon as they're able to do so. And in any event, all those waivers that they're operating under now will be no longer available after termination of the emergency period. So that's going to be this thing of saying, well, we can't do it now, and Arlene touched on this. We don't have to do this now, but boy, when that public health emergency is over, you're going to need to know that date and know when do we need to go back to how we did it in 2019, basically, with the exception of the NPP signing orders, which is huge. see if I can get this advanced. Now, if somehow you are caught up in denials, because again, UPIC activity can still occur, you may get some ADRs if you final bill a claim under pre-claim review that does not have a fully affirmed UTN associated with it. Basically, Medicare is giving some allowances that contractors can give extensions for filing an appeal for timeliness, and then they also give some allowances that they can be more accommodating for content. Are all the appeals filed, are they complete or not? So giving that leeway, that basically allows what's called good cause arguments. So they're given more leeway, but understand that because Medicare is giving the administrative contractors and the qualified independent contractors the leeway, does not mean that they actually have to grant you that. So I'm not going to put a lot of stock in getting a lot of leeway with this unless you were clearly able to show that the public health emergency affected your agency operations so much that you could not file appeals timely. Meaning any review activity and any appeals you also have in process, understand that those proceed no matter what through the public health emergency. And do not miss a deadline on those, or else you will get dismissals of your appeals. UPIC activity can occur and will continue. So again, the appeals process does continue throughout this process as well, the public health emergency. Don't miss a deadline on that basis. Now, I'm going to come back, and part of this is kind of restating some parts, and a lot of this is directly taken from regulations and changes and waivers and notifications, and boy, there's a lot of those. CMS has a whole web page with, I don't know, dozens of links to all those things that are changing. But so this next part will really address and reinforce some of the things Arlene had touched on, and I'll try and loop it back into the regulatory part. So the first one is the PHE and Homebound. Is there actually a change in how Homebound is determined? And the short answer is no. Understand that while there is an allowance there, that having COVID-19 or being suspected of COVID-19 can, I believe, clearly support that contraindication to the beneficiary leaving home. But understand that the home care definition has not changed, guys. So really, you still need to have the components of, is it a considerable and taxing effort to leave home? So basically, remember that there are really 4 parts to the homebound definition, if you will, that you need to meet either 1 or 2 of the first 2 criteria, or criterion, and then you need to meet both of the second one. So basically, is the contraindication part is supported here, but it still needs to be a considerable and taxing effort to leave home, basically to, so basically having COVID-19 by itself does not automatically make you homebound. You must still have some other debility or some other issue associated with it that would support homebound being met for an eligibility requirement. And that's a pretty important thing. Just having COVID does not make you per se homebound. Now, of course, it's pretty easy to establish. If you have it, you're probably also having significant, possibly respiratory issues or physical deficits, mobility issues, things like that. However, COVID-19 itself does not make you homebound. That's something to keep in mind. Home health cost reporting, I'm not a biller. I throw this in here as general information because you guys get the slides. Understand that there's an allowance given for your cost report, that the ability to timely file that has been substantially extended until the end of July for the most part. So there's some benefit for all you bean counters out there. Another item, again, this is taken directly from telehealth and face-to-face. This is home health. Basically understand that, and this is really where I think a lot of misunderstanding has been coming up, and Arlene can correct me if I'm wrong on this one, but telehealth does not mean for coverage telephone health. There's one thing to keep in mind. Number 2 is a lot of the relaxations in relation to telehealth really more so were directed towards physicians and other types of providers than specifically a benefit to what home health may gain from it. So basically, understand that that telehealth has a lot of definitions, has a lot of content, there's a whole FAQ section on it. I went through that. Understand what telehealth actually means before you just try and think that it means telephone calls to a physician or to the patient, the beneficiary, to meet this requirements here. And the face-to-face requirement, basically, and Palmetto had this question posed to them specifically this week, and basically telehealth has an audio, true telehealth, and a video component to it. And if you don't have both of those, you're probably not going to meet the telehealth requirements for what it actually is at a telehealth visit. And that would also apply to face-to-face. In other words, telephone itself will not support telehealth. Let's see. Home health services using telecommunications, that follows along with that. Can home health agencies furnish services using telecommunications technology? Well, yes, and you'll see on the third line of the answer here, two-way audio-video telecommunications allows for interaction. So again, they're really stressing that it should be audio-video telecommunications. They have relaxed so that there's these popular options available, more so than strictly the prior telehealth versions. But understand that telehealth has specific meanings for what is a telehealth visit, and it must meet audio and video communication requirements for it to be called telehealth. And that would apply towards any visits made in that manner, as well as face-to-face encounters. Telehealth communications and billing, this is where it gets sad in a way, in that there's all these exemptions or these relaxations or waivers, I should say, for telehealth. But basically, when you bill for home health, the only visits that need to be on your billing and should be on your billing are basically face-to-face visits, or they call them in-person here. As of right now, that is what needs to be on your bill. You cannot use a telehealth visit in home health as a visit to count towards a LUPA or an actual visit. So that really does limit in some ways the benefit of telehealth. There's certainly a lot of benefits with it, but you can't substitute an on-site visit, and you should not bill for it. If somehow you bill for it, that is going to cause a headache. Well, they say that agencies will be, Medicare says, will not be held to standards after the completion of the public health emergency upon review. If you submit a bill that is incorrect because you billed for telehealth visits as in-person visits, I would not doubt that that would cause you denials or some type of follow-up activity. And if that was a pattern, then I could see that generating unified program integrity contractor activity. So you need to be clear. I mean, mention your biller needs to know this and your staff needs to know this, that those will not count, telehealth will not count as in-person visits, and they should not be billed as such. Let's see, telehealth communications and PRN visits. Again, telehealth, in one way, it's almost like they're their own discipline provided. When you look at the requirements for them being on the plan of care and specifying what you need to be doing with those telehealth visits, basically the requirement for PRN telehealth visits is the same. So you can have PRN telehealth visits on your plan of care, but really the same requirements that would be there for an in-person visit apply to them as well. So you know, basically in a way, there's like a whole new discipline. You know, you'd have telehealth visits to do this with this frequency, with looking to accomplish this, and for PRN for these reasons. So keep that in mind when you're generating your plan of care under the public health emergency. Home health initial assessments. Can you do your initial assessment virtually or on the phone, really? And then CMS has waived requirements. And again, they specify out of the conditions of participation, allow agencies to perform the assessment via phone or record review. They basically say it's you know, a positive. They allow the patients to be cared for, the beneficiaries to be cared for in their own home, maximizing coverage. In a way, I really don't know how you would be able to complete an assessment over the, you know, as a virtual basis. And remember, you also can't bill for it. So that's going to possibly cause another confusion in that if it was simply done as a telehealth, how could you actually bill for it because you don't put that on the bill? That may cause some other issues. Home health and other assessments and updates. Again, can the agencies complete the comprehensive assessment and updates to it virtually over the phone? Again, it's an option to use these you know, telehealth or to do these comprehensive assessments. With the second bullet point, while we have provided certain flexibilities, regulations require agencies to have infection prevention program and educate them in the home. As such, we expect agencies to provide every effort to educate patients to what processes they have in place. So basically, they're stressing the education part. Infection control certainly is a huge issue during the reason for the public health emergency. And then basically, you know, I in a way, I don't see how these types of visits can really substitute for an in-person visit in certain time points, which would include those in-person, basically admission and OASIS completion. A few items here about hospice. Hospice services with telecommunications, again, can hospices furnish services using them? Yes. And actually, hospice services, because again, they're not billing per se, they bill per diem by level of care, has more flexibility, including telephonic communication, and then basically they leave it up to the clinical judgment of the hospice as to whether that meets the patient or caregiver needs. Again, because you're not billing, it puts a whole different, not billing on an inpatient basis, it puts a whole different spin on things. Hospice services are hospice face-to-face. Again, it may be done in that manner, but remember, a face-to-face is done after basically any benefit period after 6 months. So NPPs can also do it. And hospice face-to-face, it can be done via this, but basically, take a look. We do not believe that telephone calls provide sufficient information for it. So basically, they exclude telephone-only calls as being able to meet face-to-face requirements. And Palmetto basically said that for home health face-to-face requirements as well, that really, unless there's a video or visual component associated with it, it would be very difficult to meet a face-to-face requirement for home health via telephone. In fact, it really wouldn't be appropriate. Hospice claims, again, because they don't bill, hospice should only bill the in-person visits, with the exception of social work telephone calls for services. I just have a slide here for your general reference after, more so. And then virtual hospice assessments. And basically, here, they're pretty clearly about halfway down the paragraph on the bottom. An in-person initial and comprehensive assessment is crucial to establishing the patient-hospice relationship. We expect, basically, that it has to be done in person. It would be very difficult to provide a virtual hospice assessment. Now, here it says questions and discussion, but before I really go to that, I have some recap items that I want to go through, because really, with the key of today's presentation being how the regulatory effect or regulatory changes and waivers affect your business or how you provide service. And looking through these regulatory changes, I got a short list of items here just to speak on them. Is remember, homebound, let me couple overarching things here. The home health regulations themselves essentially are still there. That would be the Medicare Benefit Policy Manual, Chapter 7, especially for home health, and all the requirements that are there, the conditions of participation, 42 CFR, Section 484, and then for home health, the certification requirement in 42 Code of Federal Regulations, Section 424, and the home health skilled service requirements of 42 CFR, Section 409, Section 418 for hospice. Those are still regulations that apply. And within that, under how do all these waivers affect things, homebound is still a requirement for eligibility for home health. So that really doesn't change. The only thing that may change is that COVID-19 can help support a medical contraindication to leaving home. But the other homebound requirements, whether the assisted device issue, reasonable, considerable and taxing effort to leave home, need of assistance to leave home, all those still are required to be present. So don't think staff can think, oh, that's relaxed in any way. So in a way, the homebound requirement has not changed. The only thing that has changed is it's in one way easier to support it if they have COVID-19 or suspected COVID-19. Now, another regulatory change is relation to physician orders, more so specifically the non-physician practitioner orders. Now, that was a major change this last week when CMS allowed that this will be a permanent change. But there's a big asterisk on this, in that, and there's probably 3 asterisks on this. First of all would be that you need to make sure that NPPs can only function within your state and licensure requirements. So therefore, if the state does not allow NPPs to sign orders because Medicare says so for your plan of care, it's not going to help you. So you need to know that, because anyway, they can't sign orders, and Medicare is saying it's not going to override what your state says. Number 2 is that the regulations that I just mentioned have not caught up yet. So during the public health emergency, you will not, and supposedly during a no look back on this, you should not be held responsible to any problems that come up or any reviews. However, take a look in the benefit policy manual sometime, and just look how many times it says that a physician must do something. Take a look at the face-to-face encounter requirements. In the benefit policy manual, especially Chapter 7 for home health, conditions they must meet to be qualified for home. The services must be under a plan of care established and approved by a physician, Section 30.2. Under the content of the plan of care, who signs the plan of care? Under the care of a physician, Section 30.3, you certify the patient under, a physician certifies the patient under Section 30.5, which also then allows for home health face-to-face requirements. Orders must be signed by a physician. All these regulations there, as well as the certification requirements in the Code of Federal Regulations, 42 CFR 424.22, and all your eligibility for home health, 42 CFR 409.42. Section 4 is under care of a physician, and a physician is defined as, there's all these interrelationships. What I'm getting at here, guys, is that under the public health emergency, you may receive orders from an NPP, and that'll be acceptable, and that will continue after. But there is still a risk that until all these regulations all these regulations catch up to the revision, that there's going to be a mismatch, and that can pose some medical review difficulties down the road. Now, certainly, NPP signing orders is a major benefit. It's a huge thing we've been looking for years in home health, but it does run a risk. And that's where I went back to the statement of, if it is possible and you can still maintain your pre-public health emergency standards and requirements, then you know what? You would be basically sitting good in relation to all these evolutions or changes that are occurring during the public health emergency. So orders and certification. Even look at your plan of care content. Look at the certification verbiage where it says that I certify and basically set up for a physician to certify. If that verbiage, will be a mismatch if an NPP actually certifies the patient for home care. So you're going to need to look at your documentation and see where it references physician, and then see, is it appropriate to this revision to an NPP. Again, during the emergency, this should not cause a problem, but when that emergency is declared to be officially over, there will be a date, and as of that date, you need to be fully compliant with whatever is in effect at that time. So, I'm just saying make changes or use these waivers cautiously. Regarding plan of care and telehealth, I've touched on it. How do these regulatory changes affect that? One way, just think of telehealth, and my suggestion is as another discipline. How will we use telehealth? First of all, understand what telehealth is as opposed to telephonic communications or wellness checks or whatever you want to call. Is it actually telehealth? And then if it is, make sure that it is on your plan of care, you have orders, your frequency's there, treat it as if it is another discipline. And once you do that, sadly, keep in mind, part of your plan of care, that you need to comply with the plan of care and follow your plan of care. If there's changes from the plan of care, you need to get orders changing the plan of care. So, tread cautiously in use of telehealth. It's excellent that we're afforded this opportunity to use it, but understand what it is and how to use it. Arlene is a wealth of information in relation to telehealth utilization and compliance with it. So I would, if you have a question, there's a contact person for you in that regard. In relation to things like occupational therapy, being able to complete the initial OASIS assessment, that was an advantage. On the other hand, how many cases do you really see that are OT, basically OT only? I just don't see a major change coming from that. Basically, it's just so rare now because of the regulation, but I don't see that really changing a lot. Aide supervision, these types of things, relaxation, aid in services. How does that affect your work now? These things are deferred. Understand that if you choose to not do, especially things like aid training, then when that public health emergency is over, you need to go back through these items here that were relaxed under the waiver. Go through each of these and think, what did I change during this emergency that I now need to be compliant with after this emergency, or else you will cause yourself problems. And you may not know those problems for a little while down the road, but if you do something then that triggers a medical review or you pick activity, life will not be good for you. In relation to ADRs and appeals issues, I would just say that understand that all the appeal process is continuing. I have hearings that still occur. I'm still writing appeals for agencies. So if you get a denial, don't think any of that is suspended during the review. If you want to seek payment for your claim that was denied, you need to be timely with it and address it, because reviews can still be occurring, denials can still be occurring from various sources. And this also really goes over to Medicare Advantage plans, where I would strongly recommend you check with each of your MA providers and say, are you also following these waivers? Or, are you not? Because it's really up to them, where most of them, if they're episodic payment, do need to follow Medicare requirements. And again, the reviewer that many of them use, the particular agency out east as a contract reviewer, is incredibly efficient in utilizing little changes in regulations to deny claims, and they are fantastically efficient at that. So therefore, I would say, which goes back to my overarching statement of how to deal with these regulatory changes, if you can operate as pre-public health emergency as much as possible, after public health emergency, I think you'll be sitting much better. Let's see, my last little note here. Remember, a lot of things have not changed. The billing requirement. Here, in January 1st, our main issue in home health was probably implementing PDGM. That was hot on everyone's mind. Understand that the billing requirements under public health emergency have not changed. You need all your orders signed and dated back before you final bill. The OASIS needed to generate your HIPS code, needs to be on the ID database before you final bill. So understand that PDGM per se has not been altered during this period as well, and you need to comply with all those things we were thinking of before, including your utilization of service, things like that. And then one other reminder, I'll just put it out there because it's always out there, is that please have your therapist doing your 30-day reassessment in accordance with the Benefit Policy Manual, Chapter 7, Section 40.2.1, Subset 2. Please have them do it and compare that finding to prior assessment. That's a requirement that has not changed, public health emergency or not, and that's probably my number 2 denial reason right now. It's really close to number 1. So what I'm getting at here, guys, is that some things have changed, but other things really, it's business as usual in relation to need for orders, identification of homebound, skilled need for service, plan of care compliance, generation of plan of care, timeliness, and those things. So the waivers and the items we've identified as changed during this period, just be careful how you make changes or how you use these waivers, and understand that when this emergency is done, you will have to revert to the pre-public health emergency standards to which Medicare expects. And with that, I have run to the end of my notes so far. So Molly?
Okay, great. We do have some questions that people have submitted today, so I'll run through those. The first, is there a requirement to notify a home health patient or family if an agency has a staff member or another patient test positive, both if the team member has provided care to the patient and if they have not seen the patient?
Joe, I don't know if you hear that any better than I do. I think what you said, Molly, was if a staff member has COVID-19, are they responsible for reporting that to the patients?
Yes. Yes.
Well, I would think so. I would think so. First of all, they're going to have to report to the public health department, and I would I think that the public health department would give them direction to notify anyone they've been in contact with.
Okay.
I don't have, Joe, do you have a more specific answer? I haven't
not
about that.
I'm sorry, Arlene, not a regulatory based one, but certainly I would agree that your staff testing positive for it, notifying when that is reported to make sure that basically, it's self-contact tracing in a way, saying, I also had contact with these particular persons here. So that to me would be a notification which should be made so that proper follow-up can be made.
Okay. The next question. So NPs and PAs are able to sign orders, plans of care face-to-face in all states? Or is this still state-specific? In Texas, I was previously told that it was still not approved here, so we still had to have them co-signed by a physician.
Oh, well, yeah, it would be, the Sarlene, they would absolutely have to go according to their state regulations. It's not, it's a federal regulation has given a waiver, but it's like it always has been. If your state has something that's more restrictive, then you have to go by state requirements. And I don't have a list of those that everyone's going to have to check their state. I don't have a list of states that do and do not allow for that.
Okay, so it's state specific is what you're saying. Okay, great.
That'd be correct. There's one asterisk on that. I'm sorry. If you're on a border state, just be careful of that as well, because there are certain times when that would depend on where the provider is. So just a little asterisk along with that. Yes, absolutely, it would have to be per state specific, but I believe it would be the state where the provider is located. Provider being, in this case, the NPP.
Yes.
Okay, great clarification. Any idea when the VBP exemption info will come out from CMS?
Joe, do you know that?
I do not. That's a good question.
No.
We'll have to look it up.
No.
Okay. Have been trying to find out, but to no avail, if Georgia state practice law allows for NP and PAs to sign plan of care for home health. So this was sort of related to the previous one.
Right.
Do you all happen to know about Georgia?
What state was that?
Georgia?
Georgia. I don't. No, I'm sorry, I don't.
Okay. Next question. It seems that the requirement that HHAs and hospices maintain an effective ongoing agency-wide data-driven quality performance improvement program will remain is in contradiction to narrow the scope of the QAPI program to concentrate on infection control issues. So I don't know if that's a clarification needed. We can follow up with that one after. Next question. Do you know what the advance notification will be from Palmetto for starting RCD in North Carolina?
Joe, that would be yours.
Yeah, yes, it would. Palmetto has no specific date, but there were multiple assurances just rendered, last week, that ample notification will be given. It won't be like saying we're going to start, next Monday or something. They will give it minimum 2 weeks and hopefully more in relation to it, because they also have to make some internal process changes at Palmetto when they do it. So there is no date, absolutely no date identified right now. And when that does come out at the earliest possible opportunity via multiple methods, Palmetto does affirm that they will communicate that to give maximum lead time for both Florida and North Carolina when it will actually start.
Okay, the next question is also a clarification. Can an OT open the case and do the comprehensive assessment with or without other disciplines being ordered?
No, they did not change. They didn't put a waiver on that, as far as I know, unless you know something different, Joe. The only thing they are allowing is if the OT is in there and the nurse is not able to conduct the comprehensive assessment, that the OT can do that. But they did not say that the OT could be in there alone.
I believe in reference to, and this was just a revision, and it was revised in the last week here, where CMS is waiving requirements that the rehabilitation skilled professional may perform the initial and comprehensive assessment when only therapy services are ordered. So therefore, this temporary modification, and this is a temporary one, allows any rehabilitation professional, which includes OT, PT, or SLP, to perform the initial assessment for patients receiving therapy services as permitted under state law, whether or not that establishes eligibility for receiving home care. I would interpret that basically occupational therapy could be the only service ordered and admit and complete the comprehensive assessment. That's actually like I say, very recent, as in this last week revision to the emergency declaration blanket waiver of home health providers. You'll find that on page 19 from CMS. I believe the answer would be that OT could.
Okay, thank you, Joe.
Okay. Can PT or OT make follow-up visits using telecommunications?
Joe, please.
I would say in the follow-up visits, wow. I am not aware yet of home health home health therapy services being, they can make a visit as telehealth, but it's not going to count as an actual in-person visit. I believe in-person visits still remain in-person visits. So, they can fall within a telehealth plan of care as a telehealth service provided, but it's not going to count towards getting you out of LUPA status. And also, if it was simply telephonic follow-up, then that would really basically, I don't want to say, not to demean it, but count towards nothing. I mean, it would be a follow-up, a general wellness call. So I believe in that regard, the answer would be no, I believe, in answer to the question. It would only count towards telehealth visits, which do not count towards your in-person visits towards your reimbursement in compliance to plan of care.
Okay. Where can I find telehealth regulations?
Well, the regulations are actually part of some of the waiver programs, and there is a little bit about telehealth, and in the Medicare billing manual, there isn't much to say except that you can use it, but you can't bill for it, basically. So physicians can bill for it. And like I mentioned before, the home health agency can provide the telehealth services, and that's just going to be part of the payment that they receive in total. Same thing with hospice. Hospice is like a bundled payment type of payment resource. So the telehealth is just would be included in that. It wouldn't be a separate charge for any case in either organization. But that's where you would get the information, would be from the billing manual. Do you know the place, Joe, that's located?
Not per se the billing manual. I would recommend going to and you can come to this from any of the MAC websites. If you actually then link back to the CMS COVID-19 website,
right?
There's just all sorts of them, and there's multiple. In fact, I was checking through them again today. There's multiple links to FAQs in relation to telehealth, waivers, requirements, explanation. I know that it's not going back to the original reg, but actually it references quite a bit of that within those. There are probably 3 or 4 at minimum links to telehealth, and that's just not home health telehealth, but all types of telehealth on the CMS COVID page. Like when you go to the Palmetto, as an example, website homepage, the hot links is CMS COVID page, and that'll take you right to it. And then you've got multiple references available to link to telehealth requirements for all types of providers. Certainly we care more about home health and hospice here, but also how it's applied, defining it, all those types of things. I'd recommend that.
One more thing about telehealth is that for home health in particular, telehealth is an allowable cost. So agencies need to be really careful about making sure that they put that cost information on their cost report and when they file it, because as Medicare sees we're using it more, they will be more inclined to actually pay for the service at some point. It's probably not going to be this year, but I would expect that the reason they're making an allowable cost is they're going to track to see how often we're using it and how effective it is. And if our outcomes are improving, that will be something we can look forward to.
Okay. We've got 2 questions left. If a nurse is seeing a COVID patient and she will see that patient last on her visits, do we have to disclose to previous patients visited?
That's a really good question. I've never been asked that before. I guess, go back to the same answer I gave before. I would report it to the public health department and then get their advice as to how to handle that situation. That's a really good question. It's not like HIV where we don't report it, we don't disclose that at all. They're asking for the COVID-19 to be reported. So I would guess that would be the best thing you can do. Joe, do you have anything else to add to that?
I would. That's actually a pretty good, interesting question. That's a very good question. I would go back to, the your local county health department in relation to that and see, because obviously you are, as a provider, right, as a nurse, you're going into a COVID home and then possible, non-COVID one. So in a way, you are possibly transmitting. Of course, if you're, hopefully using proper PPE and infection control, you're minimizing that risk. But I would think guidance would come from your local health department, who would be more responsible for tracing, and knowing where the positive cases are. I'm not aware of anything from a federal regulatory comment on that. And then once you get to the states, of course, it would vary from state to state. I'm not aware of anything, as an example, in Michigan in relation to that. So I think the suggestion of your local health department for advice would be good.
I think that's a really good question, though. And I think that's something that we probably should follow up on, or everyone should follow up on, and ask public health how you should handle that and make that part of your policy.
Okay, great. And the last question, Florida is still having issues doing home testing. It isn't available yet. Any insights on this? Also, how will we be trained to do the testing, and how do we get the tests?
Oh gosh, I don't have any information on that at all. I would expect that CMS will come out with the information direction for getting that information. Joe, do you know anything different? I haven't heard anything about that.
Yeah, I've only seen things in relation to payment for tests and any CMS guidance so far. That's another one of the good ones about when the testing is out, how can, training and application on the testing. I would think, again, that might be the establishment of communication, again, with the local health department or your county group, who would be most involved in it and most having a big stake in that, saying when tests are available, what's the best way to apply it and be trained so that we're compliant with this and we're not, any way a vector of infection in doing it. But I'm not aware. The only thing I've seen on any regulatory guidance on that has been that, whether tests would be paid for or not. But it never actually speaks to the administration of the test.
Okay. That is all we have in our question box today. So I want to thank you, Joe and Arlene, for joining us to share your wisdom and your expertise with us. Just want to remind everybody who joined us today, we will provide everyone with a link to the recording and the slides. Please be sure to take the post-webinar survey, which will be emailed to you shortly at the address you used to register for this webinar. That is also where your continuing education certificate will be sent. And we just want to thank all of you for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Thank you, Joe, and thank you, Arlene. We appreciate it.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.